Now, a reverse total shoulder replacement is done for several reasons, okay? The first is that a patient has something called rotator cuff arthropathy, which is where you don't have a rotator cuff and you've developed a significant amount of arthritis as a result of that. The way that the reverse total shoulder works has been studied for many, many years. The main biomechanics is that it changes the moment arm, of your humerus, so that the deltoid muscle, this big guy right here, does the work for the rotator cuff. So if you can imagine, when you have rotator cuff arthropathy, the humeral head will actually migrate superiorly. The supraspinatus tendon, which is the top rotator cuff tendon, actually keeps the humeral head depressed. And when that's gone, it develops arthritis in an unusual pattern, different than a primary wear. And so what we're doing is we're changing the moment arm and switching the ball and the cup. The ball goes to the cup side, the cup goes to the ball side, and that changes the moment arm so that it lengthens and tensions the humerus so that the deltoid can allow you to raise the arm. It's a very reproducible surgery. Again, it's changing normal human biomechanics, so it's not perfect, but it does have a lot of roles. The second role that it has is when you're an older patient and you have what we call massive retracted chronic rotator cuff tear. So if you are unable to raise your arm because you have a long-standing rotator cuff tear that's occurred over a long period of time, when we try to repair those rotator cuffs, they don't do well. They don't heal well. They don't have the biologics to heal well. They don't get tensioned appropriately because they're retracted, just like if you tore your quad tendon or your Achilles and left it alone for many years. And so an alternative is to do a reverse total shoulder arthroplasty. The third role for a reverse total shoulder arthroplasty is for fracture, okay? So, and that is something that we've proven time and time again. In the olden days, and even 10 years ago, we used to do something called a hemiarthroplasty, which is where we just replaced the ball with the ball for a broken humeral head, and then tried to tie the rotator cuff or the pieces back down and allow it to heal. We found over a long period of time that that doesn't allow for perfect healing. When they do heal, patients do well. When they don't heal, then they are unable to lift their arm. And so we found that doing a reverse total shoulder replacement has essentially allowed to switch that component so that you don't need a rotator cuff to elevate your arm. And that works very well and is very reproducible for elderly patients with fractured proximal humeruses. The reverse total shoulder has also evolved. So in the olden days, we had a Grammont style, that was the name of it. And we had different degrees of slope of the cup from the 155 degree to the 135. And that has changed the moment arm even more to reproduce more normal human biomechanics. And so we've learned different things about pushing the ball out further and putting it in the right place, tensioning the shoulder appropriately to get better function out of the reverse total shoulder replacement. And that, again, between the two, primary shoulder replacements and reverse total shoulder replacements, because it has so much utilization, has increased exponentially over the last several years.